So let's get started. Welcome everybody. And we're gonna get started with a video.
Each of us is unique in some way.
My awesome head of hair is what makes me unique.
I love to play guitar.
I am a U.S. martial artist champ.
I am a two-time state title holder within the New York pageantry circuit.
Amida Care is more than a health plan. We're a community, we're family.
This is my place.
I belong here.
This is a place where you can be who you are and get the support you need to live a healthier life.
Thank you so much for joining us. My name is Elizabeth Aloni. I'm with Schneps Media. We are the largest media company in New York City with offering over 70 newspapers, magazines, websites, webinars, podcasts, and events throughout Manhattan, Queens, Brooklyn, the Bronx, Westchester, Long Island, and Philadelphia. Today, we're thrilled to bring you COVID-19's impact on New York's plan to end HIV. And it is my great honor to introduce Editor-in-Chief of the Gay City News, Paul Schindler. Paul?
Thank you so much, Elizabeth. Good afternoon. I'm Paul Schindler from Gay City News. We have a terrific panel today. And here at Gay City News and Schneps Media, we're proud to be bringing you this event with the sponsorship of Amida Care. It's particularly timely that we're holding this webinar right in advance of PrEP Aware Week here in New York State. In today's webinar, we will explore how the COVID pandemic has affected New York State's plan to end the HIV epidemic, focusing both on the uptake and compliance with PrEP use, but also on the broader aspects of the ending HIV plan here in the state and the city. So that I don't overwhelm you with too many introductions all at the start, what I'm going to do is introduce you to two participants who will be making introductory remarks to get us on our way, and then I'll introduce the remainder of our panel. Doug Wirth has served as president and CEO of Amida Care since 2006. Amida Care's successful care model, delivering specialized care to people needing intensive services, has empowered thousands of New Yorkers who are living in high risk for acquiring HIV, and that includes transgender people and those experiencing homelessness. Johanne Morne is director of the New York State Health Department's AIDS Institute, which was created in 1983 to coordinate the state's overall response to the HIV epidemic. The AIDS Institute's broader mission today integrates hepatitis and STD services, surveillance, opioid. Doug, I'm going to ask you now if you would make your introductory remarks, please.
Thanks, Paul. Good afternoon, everyone. As Paul mentioned, I'm Doug Wirth, President and CEO of Amida Care, New York's largest Medicaid special needs plan. I want to thank you for being here today for the discussion about the progress to end the HIV epidemic in New York during these times of COVID. We're delighted to be partnering with Gay City News for this important conversation. Amida Care provides comprehensive health coverage and coordinated care to people living with HIV, as well as people who are experiencing homelessness and persons of transgender experience, regardless of an HIV status. COVID-19 has impacted every facet of healthcare, and HIV prevention and treatment are no exception. Amida Care members have been greatly impacted by COVID. Over 300 of our members we know have tested positive for COVID-19, and we've seen a 10% mortality rate. This is an extraordinary number. And 66% of our members who have contracted COVID are people of color, people who've been gravely and disproportionately impacted by both HIV and COVID. On a broader scale, we know that some of the pillars of the state's plan to end the epidemic have also been impacted by COVID. To consider how New York State can maintain the momentum towards an HIV-free future, Despite the challenges of the current public health crisis, Amida Care is releasing an issue brief today entitled "A Pandemic and an Epidemic: COVID-19's Impact on New York's Plan to End the HIV Epidemic." I hope everyone will have a chance to read it and consider our recommendations as we work together toward the goal of ending the epidemic in New York State. On today's panel, we will hear from experts about what they've observed on the ground as it relates to HIV testing, prevention, and treatment. And today, just 1 week before the AIDS Institute's second annual PrEP Aware Week, this conversation could not be more timely. The pandemic has shined a harsh light on the ongoing health disparities that communities of color, the LGBTQ community, and other vulnerable populations have experienced for decades. PrEP uptake is a perfect example. PrEP is more than 99% effective in preventing new HIV infections, yet uptake has been the highest among white men who have sex with men, even though the rates of new HIV diagnosis are higher among men of color who have sex with men, people of transgender experience, and women of color. So it's up to all of us to break down the serious structural barriers to accessing quality, affordable healthcare, including rampant discrimination and higher rates of poverty. It is critical that the education around testing, treatment, and prevention focus on communities disproportionately impacted by HIV. Today's discussion will explore this and many other topics related to New York's plan to be the first state in the nation to end the epidemic. With that, I'm going to turn this over to Johanne Morne, Director of the New York State Department of Health AIDS Institute.
Thank you so much, Doug, and thank you to Amida Care and Gay City News, as well as all partners for hosting this important discussion. But first, to all of you that have decided to participate today, I want to acknowledge and thank you for your continued commitment and partnership in ending the epidemic across New York State. Since the announcement that New York State was positioned to end the epidemic by the end of 2020, New York State's network of providers have worked to enhance and expand on the significant advancements of the last 3 decades. This collective work has proven successful, as evidenced in ongoing positive outcomes. While 2019 data will not be released until December of this year at the New York State Ending the Epidemic Summit, what we know through 2018 data is the following. We know that we are on pace to bend the curve, the point where we have achieved fewer new estimated HIV infections than deaths among persons with diagnosed HIV. This will result in the first ever decrease in HIV prevalence and an end of the epidemic in New York State. We know that HIV incidence has decreased by 38% since the state's ETE, or Ending the Epidemic initiative, began. We know that new diagnoses continue to decrease, as well as individual viral suppression continuing to increase. Related to PrEP prescribing and utilization continues to increase, with just about 32,000 individuals with prescriptions in 2018, and continued progress in 2019 that shows us continuing to build and move forward in the number of individuals that are benefiting from PrEP, to be further detailed at our summit in December. With all that we can say related to our accomplishments, I think it is very important, and Doug touched upon this as well, that we have to maintain and continue our work as it relates to health equity, continued work to identify and address disparities, and a need to ensure of responding to the key determinants of health that impact the quality of individual health, sexual health, and overall well-being. The impact of COVID-19 on the state's goals of ending the epidemic continue to be assessed. We know the obvious impacts related to the transition of face-to-face service provision. New York State HIV service providers should be applauded for their innovation and the ability to maintain access to services and care while prioritizing COVID-19 prevention methods. Even in the face of responding to a pandemic, we must continue to find the opportunity to provide education, awareness, and access to quality and culturally responsive services. And for that, we are so grateful for today's opportunity to further discuss how we move forward with ending the epidemic, how we take the lessons learned from responding to HIV in New York State for the last 3+ decades, and how we apply that in working towards ending a pandemic as well. Today's discussion is so important, and I encourage everyone, please, to make sure you have access to the information related to New York State Prep-Aware Week, being recognized and celebrated October 25th through the 31st, just in a few short days. That you utilize the resources available on the prepforsex.org website, and that you work and continue to work in partnership across our state for us to end the epidemic. I want to say thank you to all of you. I'm grateful for today's discussion. I hope that all of you stay well and stay safe. Together, I continue to be committed and confident in our ability to end this epidemic. Thank you.
Thank you, Johanne, for joining us today. And just as a note to our audience, Johanne's going to spend as much time as she can with us during the panel discussion. It's possible she'll get called away before the hour is up. So if she disappears, know that she's gone on to something else that demands immediate attention. Before I introduce the panelists, I just want to underscore one point that both Johanne and Doug touched on, which is that though we're going to be discussing a good deal today, PrEP uptake and PrEP compliance and PrEP discussions, there are other important components of the plan to end the HIV epidemic, and we're going to be touching on those as well. They are very significant factors as well, and I think everyone on the panel will have thoughts on that as well. The remainder of our panel, it's a very, again, a very terrific group. Dr. Anisha Gandhi is the Acting Assistant Commissioner for the New York City Health Department's Bureau of HIV, where she oversees the city's response to the HIV epidemic. She also serves as the Bureau's Director of Racial Equity and Social Justice Initiatives. Dr. David Collymore has been the Chief Medical Officer at Acacia Network since 2011. In this role, Dr. Collymore provides clinical leadership in a dynamic, multifaceted organization that offers primary and specialty healthcare services, substance abuse services, mental health services, housing, daycare, and economic development to communities across the city. Dr. Asa Radix is the Senior Director of Research and Education at the Callen-Lorde Community Health Center, which provides healthcare services targeted to the LGBT community, regardless of ability to pay, at locations in Manhattan, Brooklyn, and the Bronx. With more than 20 years of experience in providing primary care to LGBTQ people, Dr. Radix is a recognized expert in transgender medicine. Ahmed Mohamed is a PrEP consumer, and he is also civic engagement and community organizer for the new Pride agenda. Ahmed is a graduate of Duke University with a bachelor's degree in public policy, and he has studied business and economic reporting on the graduate level at New York University. Again, I want to remind the audience members that we'll be taking questions from all of you in the final portion of the discussion. So please use the Q&A function in the webinar to forward me any questions you'd like to see the panel address. Before we dive specifically into the impact of COVID, I want to spend just a few minutes setting the table here. And The first question I would like to pose to our panel is, what is currently, in your view, the greatest barrier to PrEP utilization and uptake in New York, and particularly among those who are placed at elevated risk for HIV and in many cases are also showing the lowest rates of uptake at this point? Doug, did you want to comment on that to kick us off here?
Sure, Paul, I'd be happy to get us started. I think that there are a variety of reasons that we're hearing from members about their concerns around PrEP. And so we currently have about close to 1,700 members of trans experience. And about 700 of them, those members are HIV negative. We've been successful with about a 25% uptake of PrEP among transgender members who are HIV negative. And a small percentage of trans men also are utilizing PrEP. But the barriers we see to PrEP uptake among our transgender members are real questions around hormone usage and PrEP, the lack of trans-specific advertising about PrEP that says, hey, this is a real option for you, and a lack of promotion by primary care providers across the New York City. So that's really why both Callen-Lorde and Acacia Network are so critical resources and referral sources for members of trans experience who want to be able to talk with a sex positive primary care provider about whether PrEP is right for them.
Dr. Radix, can you speak to this issue of potential drug interference here between hormone treatments and PrEP, and what the science is and what the attitudes in the community are?
Yes, and I think this is, a really important question. As was stated before, I mean, there are many reasons why trans and gender diverse people are not accessing PrEP, and this was highlighted. One of the greatest is really the lack of trans inclusive and gender affirming sexual health care. I mean, before you can initiate on PrEP, you need to have a discussion with a provider that involves a discussion about your personal risk. And many providers just are not equipped to discuss sexual health, and we need to do a much better job of that. On a community level, I mean, there are different things that come into play, including people not being aware, and when they are aware of PrEP, as you highlighted, being concerned about drug-drug interactions, and the main concern being that if they take PrEP, it will negatively impact hormones, and that they will not get the full effect, whether it's masculinizing effects or feminizing effects on hormones. We can absolutely say that's not the case. All the studies that have been done have shown that PrEP, the ingredients in oral PrEP, do not interfere whatsoever with how the hormones work, the level of the hormones. And I think it's really important to get that information out into the community. And in fact, Callen-Lorde has created a brochure which is available on our website specifically for PrEP in trans communities. And that's one of the first statements that's made. PrEP will not interfere with your hormones, with the dosing or the effects. And also I should add that PrEP is not a contraindication for surgeries or other gender affirming interventions. In fact, it's it shows that you're taking good care of yourself when you've decided to go on PrEP. So those are the data.
Thank you. Ahmed, we've spoken for a couple of minutes here about barriers for trans folks. As a PrEP consumer and a member of the MSM community of color, what can you tell us about what you're hearing and seeing both in your friendship networks and in your community organizing work about barriers that young MSMs of color are seeing?
Right. It's a great question, and thank you everyone for joining us today. I think I want to begin with the community angle. As Doug was mentioning and the other panelists, excuse me, it's a myriad of issues that kind of confounding that create hurdles for people to get onto PrEP or utilizing PrEP. And as a community organizer for the New Pride Agenda, we're not a service provider per se, but we do work in education and advocacy, partnering with health service providers, LGBTQ service providers, to amplify conversations and education around PrEP. And I think this ties to my personal experience becoming a user of PrEP or consumer of PrEP. I wasn't prescribed in New York, but I think the backstory kind of relates to how there needs to be more intentional conversations on the provider side. So I began PrEP in senior year, so it's about fall 2018 or spring of 2019, so it's not too long ago. And I actually learned about it through a casual conversation with somebody I was going out with. And so I went to Duke University, like you said, and one of the things that they flaunt was, oh, we're like number 5 in like health and wellness, and look at us, we spent all this money on this new student health center. And I think for cisgendered heterosexual people, they definitely felt like there was a more intentional approach to safe sex and being healthy when you're involving yourself in sex, condoms, regular testing. But even when I would go to get tested regularly, the local Duke doctor wasn't the one who initiated conversations about being a potentially good candidate for PrEP. And so I had to ask my doctor on campus, hey, can I learn a little bit more about this? And so it was actually the students on the ground in the Gay Straight Club Alliance that were being most intentional about advocating for PrEP uptake on campus. And it's like a liberal school, and this is 2 years ago. So you would think that they would have some sort of more intentional process by which dealing with students who present, who are part of the community. And so, yeah, I think just amplifying conversations, but particularly on the provider side, does a lot of wonders to getting people thinking about if they're a good candidate.
So again, you're talking about a world-class research university. Granted, not one in New York State, but nevertheless, one that you would think would be ahead of the curve. And you actually brought the issue to your doctor rather than vice versa.
Exactly.
Dr. Gandhi, the comments that Dr. Radix and Ahmed have made about the barriers that they're seeing, how does that square with what you're seeing in the City Health Department?
Sure, thanks. So much of what has been shared already by Doug, Dr. Radix, and Ahmed are all very much resonating with what we feel are some of the primary barriers to a more universal uptake of PrEP or progress toward our goals of really maximizing PrEP and making sure that it is accessible to everybody who can benefit from it. We actually are trying to steer away from this idea of candidacy and trying to do our best to make sure that providers more universally are having this conversation with their patients so that anyone, regardless of whether they're disclosing what might be deemed as behavior that puts them at greater risk, because some people may not feel comfortable disclosing that to every provider who is able to prescribe PrEP to them. So instead, applying a more universal biomedical prevention education approach, letting everyone know that this may be an option from them and letting them make that decision. And similar to what has been named, I think, doing our work to educate providers, and we've done some of that from the health department's perspective through our public health detailing program, where we're really having those tailored conversations to support providers and empower them to have those conversations, to have these more affirming sex positive conversations with their patients and feel ready to prescribe PrEP and PEP. We also want to make sure that all of the kind of consumers that really may benefit from this are aware. And we've done that through social marketing, especially to make sure that we are dispelling misconceptions about who may benefit from PrEP. We've talked a little bit about how we continue to see inequities and that PrEP is being utilized at greater rates among men who have sex with men who are white. And we are not seeing that same kind of progress of PrEP uptake among men who have sex with men who are Black or Latino, among transgender women and cisgender women, even though they continue to make up a significant proportion of new diagnoses across New York City and New York State. And we know that there may be kind of differences in how people perceive their own risk, especially when their risk of acquiring HIV is not just dependent on their own behavior, but on the social and structural determinants that affect their sexual networks, their partnerships, their ability to have open and honest conversations within their partnerships, as well as their access to quality affirming healthcare. So that's so much beyond just what you as an individual are doing. And it may be challenging to really, without all of that kind of contextual information and those conversations with your provider, challenging to really kind of compute that, oh, I really may benefit from this. So getting more information out there that cisgender and transgender women can benefit from PrEP, can safely use PrEP, has really been a priority for us. Like Dr. Radix mentioned, we also have tried to include more explicit language in our more recent patient-facing and consumer-facing materials to make clear that PrEP is a safe option for transgender individuals as well as for cisgender women across the reproductive life course, whether they are trying to conceive, pregnant, breastfeeding, or going through menopause.
So what I'm hearing there, Doctor, is that beyond the transgender community and MSMs of color, there are other communities that more work needs to be done as well. And I'm remembering that Dr. Radix, in a discussion the other day, talked about, we often talk about the transgender community in terms of transgender women, but in fact, transmasculine individuals, there needs to be work on that as well. Dr. Collymore, how does this discussion so far square with what you're seeing both in terms of clients of Acacia and also providers that you work with?
Great. First of all, good afternoon to all. Thank you, Doug. Thank you, Paul. Thank you, Amida Care and Gay City News for inviting me to be part of this esteemed panel. I think there's a couple of overarching themes that I think have been mentioned in the responses so far. One of education and awareness. I think Johanne used that term together, and Doug and Dr. Gandhi and Ahmed and Dr. Radix also, I think, sort of underscored that. And the education really is on both fronts, on the provider side as well as on the client-patient side too. So at Acacia, we saw this early on. We were intentional about educating our providers first. Many of us that trained in the olden days, like myself, we didn't have PrEP during residency. So this is something that folks need to learn in real time and implement in real time. So we have to be intentional about educating providers. And I think there's no greater advocate for healthcare than an educated patient also. So I think Ahmed's story that he mentioned is all too common. And happens often where the patient is the one coming into the office and educating the provider. And we can't ignore that is a fact of the healthcare industry and one in which we need to empower patients and communities that we serve to have that knowledge, to understand why PrEP is beneficial for them. And I think the other piece too is that we have to sort of routinize the discussion about PrEP and the implementation of PrEP. And we saw that very early on with with HIV testing, many decades ago, that when it was sort of an exclusive process and we looked for pretty much every reason not to test. Of course, the uptake was very minimal. But when we made it a routine part of practice, it became more acceptable. It became less discriminatory, it became less judgmental. And I think we have to get to that point also with PrEP, where it's a routine discussion, where it's a discussion that's taking place in circles of friends and individuals, even outside of the healthcare setting. And I think collaboration between organizations is key also. So, Amida Care is a phenomenal partner in terms of providing resources for education for our providers and for their clients. And I'm not sure if Dr. Radix knows that we actually had an individual from Callen-Lorde come to speak at one of our provider meetings about a year ago. And that sort of collaboration, organizational collaboration, I believe is absolutely essential in getting us to the point that we need to be at.
I'd like now to, Doug, did you want to jump in there?
Paul, I just wanted to add, so because I think Dr. Callen-Lorde, Dr. Gandhi, and Dr. Radix have all spoke about the importance of the provider relationship with patients. But I also want to put a plug in here that I think health plans have a responsibility also. So health plans have claims data. They know about members who've had an STI test. They know people who've had a PEP prescription. They know people who've had HIV tests because the claims data is there. And what I want to say, and we talk about this in the issue brief, is that health plans have a responsibility with partnering with the AIDS Institute, the provider community, and the consumer community to really step up to the plate and start educating members about the availability of PrEP within their health plan. The vast majority of people living at elevated risk for HIV are in general mainstream health plans, whether those are Medicaid health plans, commercial health plans, or a ACA exchange plan. And I believe firmly that health plans should be using their data, identifying members who would benefit from receiving information about PrEP, and then encouragement to go and talk with one of their providers about their sexual health needs and whether PrEP is right for them.
I'd like to move the discussion on to layered on top of these complex issues, of course, has been the COVID pandemic in the last 7 months, which, you know, struck New York City and New York State so devastatingly. What are we, I guess the question I want to pose is, what have we found both in terms of additional barriers, but also maybe some opportunities that we've discovered because we've changed the way we do things. And so I guess I want to turn it back to you, Doug, for a moment to ask you, first of all, are there some headlines from your issue brief that goes out today that you'd like to point to and maybe encourage our audience to focus on in taking a look at that, but also talk a little bit about how Amida Care has pivoted during this period. And I think that we've seen some impressive pivots. So we'll start with you, Doug, and then move around on that point.
I think, we immediately moved from in-person, full-scale in-person operations with about 200 employees to complete remote operations. We've been successful at getting our call center up, running remotely and continuing to answer phone calls from members about their healthcare needs and services. We've actually been answering about 9,000 calls from members since the middle of March. One of the things that we did was automatically implemented a COVID risk assessment. So when members were calling us about an ID card or how to fill medications, we were talking with them about their concerns and their risks. We shifted gears to identify pharmacies within our network that would deliver medications to members at home so that they didn't need to go out and travel. And then members who had additional concerns, we even authorized or supported the fill of medications beyond a 30-day fill of HIV medications. I think one of the opportunities that definitely we've learned through the pandemic is the benefits of telehealth services. And so many of our providers moved to provide telehealth services, both in the primary care and behavioral health settings, but also AIDS Adult Day healthcare services. And so one of the things that we took advantage of, particularly in partnering with ADHD programs, was to connect members with grab-and-go meals. So one of the things that many members were experiencing because they weren't going to services or programs is that some of the supplemental food support, nutritional support that they received in those programs went away. and suddenly they were without food. And so connecting people to grab and go meals or medically tailored meals through a program that we work with, God's Love We Deliver. And so those are all some of the things ways that we've adapted the way that we work in order to continue to serve our members. I think telehealth represents a great game changer for the purposes of supporting people with PrEP uptake so that they can have their follow-up visits with a provider via a telehealth service so that they don't have to take time out of their day, possibly away from work, to go and see their medical provider.
I wanted to ask both Dr. Radix and Dr. Collymore to comment on the sorts of pivots you've seen in your work and to what extent telemedicine has either been helpful or been a barrier in terms of, particularly in terms of PrEP, but also in general terms about, let's say, compliance with therapies on the HIV positive side. Dr. Collymore, I'll look to you first.
Sure. I mean, this has truly been the most dynamic period in my career of medicine these last, I'd say 6 to 7 months or so. So, I mean, at Acacia, there's so many different methods of service that we provide that it's been a pivot on multiple fronts. So from the health center and outpatient healthcare side in RFQHCs, we also had to shift towards a virtual / telephonic method of delivery of care. We made that pivot and that transition early on, but we also saw that there was a significant need for in-person services, and we saw that rather quickly. We made the pivot also to resume in-person care, I'd say significantly earlier than many other organizations after just a few weeks of being in the sort of stay-at-home pandemic. Because we saw that many of our clients and patients did not have access to technology, maybe did not understand the technology. So in-person services were absolutely essential. And we used them as an opportunity to teach the individuals, if they had access to the technology, how to become comfortable with it. One of the other key features I think that really helped us to be successful through the pandemic was the utilization of peers. You know, in reaching out to patients and clients, there's only so much capacity that the provider themselves has in terms of how many people they can reach out to. So we saw that there was a significant reliance on our peers, first because of their level of engagement with the clients and patients, but also just because of the ability to reach out to them, to connect with them, and then to identify those that had a significantly greater need and needed to have a more urgent provider interaction. We also have the pleasure of operating a skilled nursing facility, Casa Promesa, which is dedicated towards the care of patients with HIV. And as you know, the skilled nursing facility industry was really hit hard by COVID. And we saw ourselves in a position to have a need to provide greater provider access within the skilled nursing facility to navigate through those most difficult times. So we actually shifted providers from the outpatient setting into that setting in order to provide that care. You know, throughout our housing components, you know, we did greater screening. We found ourselves doing testing within those facilities, isolating within those facilities, and really putting forth great efforts to contain and to overcome, to an extent, the pandemic. So many points of in areas where we had to make a shift, that when we look back on the great work that was done, and we're very proud of our staff, proud of our patients and our clients, you know, and still, you know, continue to be sort of in that mode, because we're not out of the woods yet. We recognize that, and we cannot become complacent and become comfortable and succumb to what many have termed the COVID fatigue. So many points of shift, but telemedicine, I believe, was a necessary shift, and it's a modality that is here to stay. Our goal and our desire should not be to go back to healthcare as it was back in January, February. We should be utilizing everything that we've learned since the beginning of this pandemic, and moving forward with a new method, modality, and style of healthcare.
You know, on that score, I'm particularly interested in knowing, do you think that the experience of Callen-Lorde is that these conversations may actually be easier to have, more nuanced via telemedicine, or is that a wash? What's your judgment on that?
So, you know, I want to say that, you know, we have done many similar things at Callen-Lorde as far as, you know, the shift from on-site care to telehealth. I think one of the issues, of course, is that there are gaps, right? As was said previously, not everyone has access to the technology to be able to do video visits. Some people don't have access to a smartphone. They don't have access to any phone. We see people who are, you know, unstably housed and homeless, folks who are in shelters. Sometimes the environment is not conducive to either telephonic or video visits. So I think, you know, we always need to keep in mind who is being left, you know, who's being left behind. I wanted to add a few things that that we've noticed. I mean, certainly for people who have already been on PrEP, you know, obviously it's very easy to continue PrEP, to be asking questions about adherence by phone. What hasn't been as easy has been getting lab testing. You know, we've taken direction from New York State. We're not requiring mandating 3 monthly tests and allowing either for HIV treatment or for prevention. Many times people have had to go to external labs closer to their home, and understanding that when people come to Callen-Lorde and get blood tests done, you know, they're in an affirming environment. And when they go to a lab that's close to their house, it may not be. So one of the other things we've been doing is training labs. We actually have 3 trainings coming up where we do cultural competency so that, you know, people know how to take care of our clients. For example, you know, just names and pronouns and being appropriate about that. The other thing we've noticed is that around new starts of PrEP, new starts are lower. One of the things that will initiate a conversation about PrEP is having a positive result for an STI. And as we know, many STIs, especially anal STIs, are asymptomatic. So, you know, you're not going to pick that up on a phone call. You're going to pick that up on a lab test. So I think we need to also keep in mind where we're falling short. And I think as we're starting to bring people back and doing more testing, we're starting to see STIs again.
Dr. Gandhi, you know, a couple of points that Dr. Collymore and Dr. Radix brought up, I wanted to follow up with you on. You know, first of all, I know that a big barrier in all of this is the initial connection to care that an individual has, which remains a problem both in New York City and in American society generally. On top of that, we've seen closures of at least temporary closures of some of the sexual health clinics in the city. And so I'm wondering, and then also there's the barrier in terms of internet access. So what is the assessment at the Department of Health in terms of how successful the pivots that we've seen have been? And I'm thinking particularly there about new uptakes of PrEP. In other words, folks who have not been connected to the healthcare system, or at least not been connected to PrEP. How well is that going during this period?
Sure, thank you for that question. So I can speak a little bit of what we've seen so far among our Placer network providers, who are those that we help support and fund and provide technical assistance to as they provide PrEP services, related kind of supportive services, and also linkage to HIV care and treatment if is what is needed. And we did see a dip, I think, corresponding with the peak of the pandemic here in the spring. But a lot of that in terms of PrEP initiation is actually rebounding across many of our priority populations. And we actually didn't see a corresponding dip at that time in March and April in terms of PrEP follow-up visits. So that's really heartening to know that there was, you know, some amount of sustained kind of engagement with PrEP services for people who had already started it. I don't think we're at the point yet where we can determine who, you know, are these folks, are the folks that are newly initiating PrEP, people that, you know, really had not engaged with healthcare, with these kinds of services before. But I think we are, you know, heading back to a place, especially as clinical services start to reopen more in person, of people then having that option of engaging in telehealth or engaging in in-person services. And that's true for our sexual health clinics as well. Several of them have reopened, and they're also offering telehealth services for a variety of sexual health needs.
What boroughs have they reopened in, just for our audience's edification?
Oh, sure. I'm going to double check what those sites are,
Okay.
and we'll circle back. But I did want to also acknowledge to the point of, you know, that knowing that the technology barrier can be real on the side of our Ryan White Part A funded care, which is to be delivered to people living with HIV, that we've really been doing our best to support providers in issuing kind of memoranda on a regular basis to let them know what resources are available to support mobile phone plans and internet services for their clients, offering TA on how to deliver telehealth to really try to reduce those barriers. And some of our Placer Network providers actually have innovated and created kind of either phone booths or mobile units where people can access technology and devices to have their telehealth appointments when they themselves don't necessarily have access to that at home, or maybe unstably housed and not have a place to do appointments when clinical sites are really offering more of that remote service. So we're really amazed by the ways that a lot of community-based providers and organizations have been able to pivot and innovate in this moment. And I'm just gonna let you know real quick. So our Fort Greene, Chelsea, and Jamaica clinics are all open. And then there is a daily telehealth option Monday through Friday. And I believe that we are on track to be reopening our Morrisania clinic as well in the future.
Great, thanks for that information. That's helpful to our audience. Ahmed, your personal story obviously demonstrates the importance of peer-to-peer education. But I'm wondering, first of all, what has your personal experience with telemedicine been? And number two, in the communities that you do work in terms of organizing work for the new Pride agenda, not necessarily on these issues, but to what extent is this lack of connection to internet services a real issue and a real barrier?
Right. So I'll start with the personal. I feel very privileged in that I was on PrEP before this pandemic and I landed in New York. And my provider offered a very smooth transition to continue telemedicine. I can't say that that's the same for most of the people that I'm speaking to on the ground. As I mentioned earlier, the new Pride agenda isn't a service provider. And so what we do is amplify the conversations and the services that our partner organizations or coalition organizations are engaged in. A couple months ago, I got a random text from a Housing Works employee asking if I was on PrEP and seeing if I wanted to take steps to follow up to become on PrEP or start using PrEP. And so I am seeing that both directly, the same pivot to telemedicine. At the new Pride agenda, we were planning on going into the communities and doing education modules on PrEP, what it means, how you can access it, and then referring them, as we're not medical providers, to local doctors in their community. We instantly pivoted to providing those virtual town halls virtually online. And I think one of the things that we've been touching on, but I want to just put a fine point on, is that it's a very confounding issue. And if you are dealing or struggling with mental health or finances, it's hard to see past tomorrow. And PrEP is a drug that more or less, it's not like you have to it's demanding in the sense that you have to be taking it every day. And so I've been just seeing that people are emphasizing conversations around mental health and financial security, mutual aid funds that people in the community are doing. A bunch of our community members engage in sex work, and our sex workers, and that's their financial income. And so to not be able to engage in their trade in this time is very, very acutely impacting them. And so I think just one of the things that I'm seeing overall is a general sort of checking in on people in the community with regards to their mental health and how they're holding up during the pandemic. Then I think the conversation could pivot into more direct, intentional PrEP uptake, but it's hard to get to that point when somebody isn't in a state of mind where they can want to be on PrEP.
And obviously there, you're also referring as well to housing instability as well. I want to make sure we do move on to the broader effort of the plan to end the HIV epidemic, and important portions of that, in addition to PrEP uptake among those who are negative, are regular testing, first of all, for HIV, and then getting folks who test positive onto treatment and working on treatment compliance. So I guess I'll turn first to you, Dr. Gandhi. Where are we on those pieces of the plan?
I think in a lot of ways we're doing, really great work, both in New York City and New York State, and we are so grateful for that deep partnership. I also want to acknowledge this is not just a government effort. This is a deep community effort as well, and we cannot get to our ending the epidemic goals without this really broad cross-sector kind of collaboration and partnership. And we are very much indebted to community partners, stakeholders, and activists to keep us pushing toward our goals. New York City, based on our 2018 data, was the first US city that was part of the Fast Track initiative to hit the UNAIDS 90-90-90 goals, which is really fantastic. It means that, we had 90% of people over 90% of people living with HIV were diagnosed. Among people diagnosed, 90% of them were on treatment, and among those who are on treatment, 90% of them were virally suppressed. So we did hit that across the city overall, and want to continue to make progress to make sure that we're really hitting those goals in all of our priority populations as well, because we've seen some disparities in that progress across racial ethnic groups. So we, continue to build on the ETE blueprint that work was initiated by the state, and our New York City plan really hits on those initial 3 pillars of, making sure that we are getting to this, sort of universal testing, really effective prevention, improving viral suppression, but also, pulling in from the national Ending the HIV Epidemic plan, also expanding our efforts around enhancing methods to identify and intervene on HIV transmission networks. So using molecular HIV surveillance and some new kind of technologic approaches and techniques to really do this very precise intervention when there are new kind of clusters of new diagnoses. And also really taking a very intentional equity-focused approach. So in all of our strategies and approaches, being intersectional, strengths-based, anti-stigma, and community-driven, and making sure that our programming mitigates racism, sexism, homophobia, transphobia, and other systems of oppression that we know exacerbate HIV inequities. And so this again needs to really be a partnership, but I think I'm very excited about the new data that we'll get to discuss and review at the ETE Summit and following World AIDS Day at both the city and state level, and will help us even more precisely work toward our goals. I'll also note that we're in a process now, because of that federal initiative that was introduced last year, that New York City has had an additional investment of federal resources, and again, in partnership with the state, are in a process now of doing some more intensive community-based planning to really drive the next phase of our ending the epidemic work. So we put out a survey, we'll be having some additional listening sessions. That work has been going on for some months and really will continue to inform and shape the way that we create programs to respond to community need.
Yeah, one quick follow-up, Doctor. You know, the HIV epidemic has often been described to me as really a lot of different epidemics going on at the same time. So to the extent that there are communities, populations, demographics that we're not hitting as successfully as others, how big a concern is there that while we may in a macro sense kind of end the epidemic, there will be continued epidemic going on in smaller populations? How big a hurdle and barrier is that?
Yeah, that's a great question. I'm reminded of, you know, several years ago, Dr. Bob Remian had noted that, you know, we may hit these 90-90-90 goals, but it may take us a whole lot longer to reach that other 10%. And I think you also touched on this point, and Doug mentioned this at the beginning, that we are seeing this same kind of disparate impact of COVID-19 on populations that are disproportionately affected and burdened by HIV, by HIV as well. And so I think it really takes some disruptively innovative approaches to make sure that, you know, we're not just sort of doing a one-size-fits-all approach, but that we are thinking about localized, tailored, and culturally responsive approaches to intervening on the HIV epidemic and meeting people's needs. I think we've seen a lot of that innovation in this time when we've faced really unprecedented challenges to delivery of care and seen like local community-based organizations really respond with outreach efforts, with care provision strategies to really meet the moment. And so we will continue to need to do that. And I think do that with the mind to be driven in our approaches by community stakeholders.
Doug, I see you shaking your head. What's the perspective from Amida Care on this?
Yeah, well, I love everything Dr. Gandhi just said, and many aspects of it are included in the report that we've released today. What we need to do is to make sure that the focus of public health money is funded in communities placed at highest risk. And I say it that way, communities placed at the highest risk, because the intersectionality of structural racism, homophobia, transphobia, and educational discrimination, those things put communities at risk. So we need to do things that are focused on a number of different spaces. I want to bring in sort of, you know, government's role to be a better partner. There are legislative reforms in New York that are necessary to help us end the epidemic. The Walking Well Trans legislation needs to be moved forward in the legislature, and the governor should sign the bill to support members of our trans community and protect them from being unnecessarily harassed by the police. One of the participants talked about, do you know that New York State does not have a comprehensive sexual education plan across all of our schools, all of our kids? That bill needs to be moved forward in the legislature to support the kind of education and conversations, Ahmed, that you were talking about. We ought to be having those in the public schools with kids and teaching them a sex-positive sexual health message that empowers them to talk with their providers. We talk about in the report, we need to strengthen Medicaid. So one of the things when Dr. Radix and Dr. Collymore were talking about clients, patients not having access to smartphones or being able to participate in telehealth services, we should strengthen Medicaid. Be very careful of any attempts at the state level to defund or cut Medicaid funding. This HIV is a disease of poverty, and we need to protect healthcare access through Medicaid. We could also expand, why shouldn't Medicaid cover a smartphone or the cost of a program so that members and patients could actually provide and get those healthcare services through the telehealth. We ought to make sure that all health plans are providing and providers provide access to rapid start of HIV therapy upon diagnosis. We should not make people wait. We know that if they get engaged in care and you suppress HIV early on, they're more likely to be virally suppressed down the road, and they're more likely to stay in care. And one of the personal things, Amida Care as a health plan, we're measured against cancer screenings. But there's no quality measure that measures health plans around their activity to make sure that we're promoting HIV testing and access to treatment. And we think that the state could play an innovative role of actually creating new quality measures to require health plans to be measured against how are they performing with regard to advancing testing, treatment, and prevention of HIV.
I'm going to ask the patience of our panelists and our audience to hang on for about another 7 or 8 minutes, because I'd like to just get a couple more comments and then hit just a couple of the questions from our audience. Dr. Radix, in terms of the other components of the plan, testing and getting folks onto treatment and into compliance, what is Callen-Lorde seeing right now?
Well, I think across the board, many people are seeing HIV testing rates going down. However, but they are bouncing back. I mean, this was, April, May. We've been able to do things, for example, like mailing people home test kits. We've been able to increase access to testing in people's neighborhoods. We certainly are doing on-site testing now. So all of those things are much improved. We have a protocol as well for rapid start of antiretrovirals that has been adapted for, this time of COVID and, telehealth. So I think we're catching up, and we're doing as much as we can. And I have to say that a lot of this is due to immense support really from the AIDS Institute and great guidelines that have really assisted us.
Dr. Collymore, the same question.
I mean, I would echo a lot of what has been said. I think testing is a vital part of identifying those that are undiagnosed. So we've continued to do or to increase the testing that we've been doing throughout the year. I think once identified, I think Doug and Dr. Radix made a great point about rapid start of treatment. That's something that internally we've been emphasizing almost at every provider meeting, monthly provider meeting that we've had. I think, again, that's an opportunity, I think, with community education where we can educate the community also more about that. I think retention and care is key. And the care, I think Dr. Gandhi and Dr. Radix may have alluded to it, really has to be individualized. So that 10% that we have not suppressed, we really need to look at each individual and see what needs to be done to get that person to be suppressed. And that, I think Ahmed mentioned it, maybe a greater emphasis on mental health. The body is so interconnected that you cannot adequately treat someone's physical health condition without addressing their mental health condition. The reality is that all of us in the midst of this pandemic have had some level of mental health strain. Whether it's diagnosable or not, this has been a really trying time for many. From a mental health standpoint, from a physical health standpoint, from a financial standpoint, we often say that housing is healthcare. So an individual that is unstably housed, that's an issue that needs to be addressed before we can even attempt to control their HIV. So there's so many fronts that we have been working on that we need to continue to work on. The interconnectedness of organizations is key. No longer can organizations compete over patients. I always say there's more than enough individuals that need our help. But if we work together, and that working together is between healthcare providers, health plans, public health entities, patient advocate organizations, community-based organizations. If we work together, then we can move the needle even further and hopefully get from that 90 to 95, and then continue to make progress towards truly ending the epidemic.
Hey, Paul, I want to put a plug. I'd like to put a plug in here for employment, living wage employment of consumers, people living with HIV. So one of the barriers to Rapid Start really is just people's fear and panic and concern about what that means for them. The AIDS Institute has created a consumer certification program. Many of our AmidaCare members are completing that certification program. And we have been advancing access to living wage jobs with some city council and the epidemic money funding consumer positions out in the community. But when we talk about rapid start of treatment and a particular patient is concerned, not really ready to begin right away and has concerns, and the doctor, the nurse practitioner can answer so many of those questions. But it is really powerful to be able to have a conversation with a person who has lived experience as someone living with HIV and having been on treatment. And so I think the other piece I want to add, Dr. Callen-Lorde, to what you're saying or enhance, I guess, is really the role of people living with HIV, of having living wage jobs to be a part of the solution in ending the epidemic in New York. It addresses poverty and social determinants of health, and it gives people an opportunity to use their lived life experience in service of ending the epidemic. And I think we should work very hard to create more and more opportunities for HIV positive persons who are virally suppressed to lead the way with people who are out of care or newly diagnosed.
Ahmed, in your peer network, are folks getting tested enough? And those who test positive, are they getting access to care? Are they taking the initiative, or are there barriers? What's your experience there?
Right. I think there always could be like more room for improvement, obviously, in testing and following through. I think if I can, I wanted to emphasize something that Doug said earlier, which is that changing the law is so crucial to cultural change, particularly sexual comprehensive sex education across New York State. I would say that's especially the case if the individual in question values don't necessarily align with like that of their household or family members. You kind of run out of options to like learn about yourself and how to become in control and empowered by maintaining good sexual health. And another nuanced thing from my experience, but I think it speaks to the individualization that was touched upon earlier, was when I got into PrEP, my parents didn't know that I was gay. And so I was dealing with being insured through my mom, but also not wanting her to know that I was trying to get on this medication. And so those were conversations that I had to initiate with my doctor, as opposed to like the provider potentially taking the initiative to want years. And so I think that ties into some disconnect between an individual who identifies as queer and perhaps like not having that support in their household. It definitely should come from the schools, and then also a little bit more from the provider side and in the community as well.
We had a couple of questions from the audience. I think we can get through them quite quickly. There was a question about requirements for additional training for health professionals, and Doug had answered that question via chat, saying that there's legislation on sexual health education that is currently before the legislature. And there's also a question from someone whether PrEP could be taken after exposure, and I had answered that. And it's important to underscore that we're talking there about PEP, which is post-exposure prophylaxis. It's similar but different, and folks should know the difference between those two terms when they're reaching out for help in those hours after they feel they may have been exposed. The questions that I'd like to get some quick answers from the panel. One person asked whether a young person as young as 13 would be an appropriate candidate for PrEP. Dr. Gandhi?
Yeah, so there are guidelines around this, but acknowledging that individuals at 13 and older can be seen and receive PrEP and PEP services, and there is some, they can be seen through our New York City sexual health clinics, regardless of their ability to pay or immigration status. And so there is support for PrEP services for adolescents.
And then one other question for you, Dr. Gandhi, which is, can you give us a quick way for people to identify those telemedicine opportunities that you mentioned that the health department has?
Sure. So on our health map, so if you look you can Google NYC Health or Health Map PrEP. On our health department's website, we are updating that very regularly in terms of providers that are offering PrEP services, and you can even select based on the population. You can look at a map and see what's close and convenient to you, who has experience serving patients or clients like you, whether they have after hours, outside of business hours. So that is readily available.
Okay, great. And this is a question that I, most importantly, should not have forgotten to mention, which is, what is the experience of folks with the senior LGBT population? Is there anyone who wants to offer a specific bit of wisdom about how well we're doing in terms of reaching out to older LGBTQ folks on both PrEP, but also about testing and connection to care?
Most of the data, this is Doug, most of the data that I've seen about PrEP access by persons over 50, there actually have been significant increases and uptake in PrEP on particularly gay men over the age 50 or older. But most of the data that I've seen suggests that the largest amount of uptake in that over 50 crowd of gay men has been among white gay men. And so I think the same structural barriers that exist around younger men of color probably exist in terms of an older, over 50 gay population, gay community.
Anything else, Dr. Collymore?
I was just going to add in there that, we always have to be cognizant of the diversity of our patient population. So if there's an older individual that may not necessarily utilize social media in the same way as a younger population, we have to tailor our advertising, our marketing, our educational resources to meet the needs of our community. If there are individuals that do not have access to technology and may not be on social media, regardless of age, we have to tailor our educational resources. And then there was a comment earlier about legislation around education for providers. And while we're in the midst of waiting for that, it doesn't prevent or prohibit organizations from I don't want to say imposing, but implementing their own educational requirements. And I can recall, almost a decade ago at Acacia, when we wanted all of our primary care providers to become HIV specialists. We provided additional reimbursement for CME if it was HIV specific. We allowed additional time. We did the same thing for hepatitis C. So I think organizations should be proactive and implement their own educational incentives and requirements regarding education for providers, and then really be intentional about tailoring the educational resources for patients.
Okay, with that, I'm going to have to say that I didn't give any of you enough time to chat. This has been a great Great forum. We've gone 15 minutes over and kept almost all of our audience. So I think that's a great success. I want to thank all of you. I want to thank Amida Care in particular for sponsoring this event. And I want to thank all of you in the audience for participating. Any follow-up questions, please feel free to email me at editor@gaycitynews.com. Thanks everyone for participating. And we're going to close with, again, a look at the work that Amida Care does. Thanks very much.
Each of us is unique in some way.
My awesome head of hair is what makes me unique.
I love to play guitar.
I am a U.S. martial artist champ.
I am a two-time state title holder within the New York pageantry circuit.
Amida Care is more than a health plan. We're a community, we're family.
This is my place.
I belong here.
This is a place where you can be who you are and get the support you need to live a healthier life.
Thank you and good afternoon.